Hi, my name is Ali Keogh, and I'm an ER physician at St. Vincent Medical Center. And I thought this would be a good case to review. It illustrates an important EKG concept. Um, so this was a 45-year-old male who called EMS for acute onset of central chest pain with radiation to the bilateral shoulders. He had associated shortness of breath. When EMS arrived, he was hypertensive, he was diaphoretic, he received a full dose aspirin and 2 tabs of sublingual nitro, and he had some improvement of symptoms after this. Rhythm strips on the field showed a left bundle. There was no previous EKG for comparison. He arrived code 3 to St. Vincent due to his concerning story and his appearance. A STEMI was not activated on the field. So when he arrived to St. Vincent, this was the EKG that was done upon arrival. So I'll just take a look at this EKG and see if you think you should activate the cath lab based on that EKG and the patient's story. So there's no previous EKG for comparison. When the patient arrived, he hadn't been to our medical center before, and he had no previous cardiac history. So we'll get back to the EKG, but I'm just going to go to the next slide and review some of the basics of left bundle branch blocks and how to identify ischemia in the presence of a left bundle or a ventricularly paced rhythm. So in normal, a left bundle branch block patterns and ventricularly paced rhythms, they have to meet several criteria they have to meet several criteria. So left bundle, usually there's a prolonged QRS of 120 milliseconds or more. There are large S waves in the anterior precordial leads, as you can see here. There's broad monophasic R waves in the lateral leads, and also an absence of Q waves in the lateral leads. So this EKG would meet criteria for a left bundle. And usually when patients have a ventricularly paced rhythm, it's a similar pattern as well. And also a unique thing with V-paced rhythms or left bundles is there's a rule called the rule of appropriate discordance. And so this makes it difficult to identify STEMIs or ischemia in patients with this type of pattern on their EKG. And so what it essentially means is that it's normal to have some ST segment deviation opposite to the direction of the QRS. So if the primary voltage direction of the QRS is pointing down, as you can see here, it's normal to have some ST segment elevation. That's normal. So you could see that here. This is another graphic that displays that. So if the primary direction of the QRS is down, it's normal to have ST segment elevation in the opposite direction. If the primary direction of the QRS is up, as you can see here, it's normal to have a little bit of depression. So this is called the rule of appropriate discordance. So it makes it difficult to assess for ischemia in the presence of a left bundle or V-paced rhythm. And another thing to mention is that the presence of a new left bundle is no longer an indication for cath lab activation. This was removed from the guidelines in 2013, as you probably already know. So back in 1996, Scarbosa developed a algorithm to help identify ischemia in patients with a left bundle. And this can also be applied to V-paced rhythms, although it's a little bit less sensitive. So you can see in the graphic on the left-hand side of your screen, if you have concordant ST segment elevation, when the QRS is primarily pointing up of 1 millimeter or more, in only one lead, doesn't have to be 2, like in a regular STEMI, this would meet criteria for acute ischemia or STEMI. And so he used a point system. So this, if you have concordant ST segment elevation you'd get 5 points. If the primary direction of the QRS is pointing down and you have 1 millimeter or more of concordant ST segment depression in the same direction as the QRS, that would also be signs of acute ischemia, and that would get 3 points. If you have excessive discordance, so remember it's normal to have a little bit of discordance. So if the QRS is pointing down, it's normal to have discordant ST segment elevation. However, if it's 5 millimeters or more, that would be considered excessive. And so that would be a sign of ischemia as well, but that was less sensitive. That's only 2 points. And so in his criteria, you need 3 or more points to activate the cath lab. So in his studies, it showed that a score of 3 or more points is 90% specific for an MI, but not very sensitive. So if you do see this, one of these things, especially concordant ST segment elevation or concordant ST segment depression, that'd be pretty sensitive or specific. If you see those things, they likely have acute ischemia and likely a STEMI. So that'd be, consider activating the cath lab based on that. However, they found after the third criteria C was not very specific. And so Smith, back in 2012, developed a modified Scarbosa C. So the third criteria is Scarbosa C. He modified that. And so instead of just an absolute number of 5 millimeters or more of excessive discordance, he used a ratio instead. So instead of just an absolute number, so say you have the QRS direction pointing up primarily, if the size of the R wave, so if the ST segment deviation here, so if you see this here, if this is over 25% of the R wave, as you can see here, that would be a sign of acute ischemia. So it can be if the QRS is pointing up primarily or pointing down. So in this case, you can see the S wave. This is the S wave, and this is the ST segment deviation. So this ST segment deviation, if you move this down to the S wave, if this is 25% of the S wave or greater, that'd be a sign of acute ischemia. So in this revised criteria, they didn't use a point system. They just said if they had this, and if they had this finding, that'd be a sign of acute ischemia. So that's something else to consider. It still is not as sensitive as the other criteria. The main things to remember is just concordant ST segment deviation. That's the main thing to remember. That's the most important thing in assessing for ischemia in a left bundle or V-paced rhythm. So this is a nice table that reviews the American College of Cardiology and American Heart Association indications for cath lab activation compared to the European Society of Cardiology indications for cath lab activation. And so if you look on the table on the left-hand column, you could see the indications for cath lab activation from the AHA. If you have ST segment elevation and 2 contiguous leads, you have a post-arrest ST segment elevation and contiguous leads, a posterior STEMI, and a non-STEMI ACS with intractable ischemia, hemodynamic instability, acute heart failure. However, left bundle plus Scarbosa or pacemaker plus Scarbosa are not in those indications for cath lab or STEMI activation, which is interesting, but they are in the guidelines for European Society of Cardiology. So just something interesting to note, I got this table from Amal Matou's website, and he has a lot of great EKG cases for review. I'd highly recommend taking a look at it. So if we go back to our original EKG, this is the same one when the patient arrived to the emergency room. If you look at it again, you could see in the inferior leads that the primary direction of the QRS is pointing up. And you can see if you draw a line from the TP segment to the ST segment, there's about 1 box of concordant ST segment elevation there. And if you also go to the other inferior lead, AVF, if you draw a line from the TP segment over and up to the ST, and compared to the ST segment, you can see one box of ST segment elevation. So this would be consistent with acute ischemia in the inferior leads. So they activated the cath lab, they took the patient to the cath lab, and the patient was found to have a total occlusion of the RCA, and they put in a stent and opened it up. And here's the post-cath EKG, and you can see that those inferior ST segment abnormalities have resolved. So I think EMS did a great job of bringing the patient code 3 just because of the patient's concerning story, and because the patient came code 3, we're able to get the cath lab mobilized quickly. So I think EMS did a great job with that. And that is it. Thank you so much.